Hey everybody, so today we're going to learn a little bit about tracheostomy care and about how to suction and care for a tracheostomy or laryngectomy tube. So I'm going to come around over here and let you see what we're going to be working with. Make sure I have everything together. So the first thing that I want to do is assess my patient when I'm looking at a trach or a laryngectomy stoma. So this particular patient has a tube or tracheostomy or laryngectomy tube. They do look much the same. One difference is that the laryngectomy tube will be much smaller and the tracheostomy tube is much larger. The main thing to know when you're assessing a situation is if you know the patient's history. Is this just a temporary trach, a permanent trach, but the larynx is still intact, versus a total laryngectomy where the larynx has been removed and the airway has been completely reorganized to be an official neck breather. So first, what we're going to do is assess if the airway is patent. My patient's breathing. Is their chest rising? Do I hear any audible wheezes or sounds? Do I feel like they are breathing at a normal rate and rhythm? Do I feel that do I see any drainage? Do I assess their oral cavity? Does it look dry? Do I see that they're able to breathe at all through their mouth? Do I feel like they're receiving oxygen through their mouth? Because that might be minimal air flow for a trach. So I'm assessing that. My trach collar is intact. So I'm looking at the collar around the patient's neck. It is intact. I see that this particular trach tells me a lot of information on the actual adapter here. It says it's a no cuff. It's a size 5 Shiley, and it is a do not clean or reuse inner cannula. So there are lots of different types of trachs. There are disposable trach inner cannulas, and there are non-disposable. Typically, your non-disposable is going to have a number or some sort of information on the side of it, whereas it's very clear on the disposable, it says do not clean or reuse. So we know if we needed to change out the inside inner cannula of this trach, that we would just get a brand new one during our cleaning and dispose of this. This one, however, we would not. So this one actually goes into the trach piece itself and adapts like that. Okay, so we know that for dealing with the trach or the airway or the laryngectomy stoma, that we need to be sterile, because that is actually going into their airway, down into their lungs, bronchial fields, all those things. So the first thing that I want to make sure is my airway patent? Patent means my patient's breathing. I don't hear any stridor. I don't hear any sounds. So I feel like my patient's airway is patent. So before I go messing with the external area of the trach, I always want to make sure I have on gloves. Sterile procedures would be if you were going to insert anything directly into the tube, but right now I'm just looking. So I have a little example. I had a patient one time who had a laryngectomy. She did not sound very good that morning. I had to auscultate her lungs. She did sound very wet, very crackly. She was having lots of mucus production and coughing the mucus out of the trach. So later in the day, she called on the call light and I went in to check on her, and of course, she was holding her chest saying, I can't breathe. So like any good nurse, the first thing you always think about doing is, okay, I need to suction her. So I got my sterile gloves on. I went to get my sterile kit for my suction adapter, which this is the kit that you have that we will at some point practice. So I have my sterile gloves on. I just put them on and I'm going to suction my patient. Well, when I went to attach it to the suction, she's struggling to breathe. Her face is turning blue. She's turning different colors. I went to suction her, and as soon as I stuck it in, she couldn't breathe. Immediately there was no air and she was going like that. So I took it out. I thought, well, I can't, there's something obstructing the area. I can't get my suction catheter in, so obviously it must be something very big. So my next step was, let me take out the inner cannula. So as soon as I removed the inner cannula, she went and there was air. I looked inside the inner cannula and there was a huge green mucus plug that was occluding the trach inner cannula, and it was disposable. No, I was not sterile, but did I save my patient? Absolutely. So then I got re-sterile, I cleaned the area, I suctioned her main line, the main cannula, really well, cleaned it really well, and I got her a new inner cannula and placed in there. So that was one way that I could maintain a patent airway, is through suctioning or cleaning the cannula. If this had been a non-disposable, then I would have had to follow a sterile procedure to clean the non-disposable trach and then replace it into my patient. So for suctioning, for a laryngectomy tube, they do not always have an inner cannula. They do sometimes, sometimes not, but trach care essentially is about the same, whether it's a laryngectomy or a tracheostomy. It's a stoma in the neck that goes to the airway. It's important to know how to care for it. So first, let's review suctioning. So I would open my kit, place it on a good area, good working area, don my sterile gloves. In your kit, your snake, or inside is your actual suction catheter. Looks like a catheter, very small suction catheter. This is all sterile. And sometimes it comes with a little plastic cup. The little plastic cup is appropriate for you to put sterile water or saline in to irrigate. Sometimes the mucus is so thick that it requires a little bit of irrigation, and also helps you clean out the suction catheter if you were to get a lot of mucus and things inside here, to keep it clean in order for it to work. Because we know that if this occludes just like a straw, it's not going to suction what we need it to. So when I'm preparing to suction, I want to make sure that my patient is hyperoxygenated. Okay, well, if my patient is normally breathing room air, hyperoxygenating for them is to breathe the normal room air, taking some deep breaths in and out through their trach. If they require oxygen, so if they had a trach collar with oxygen flowing into their trach, that would be hyperoxygenating for that patient. If the patient is ventilated on a ventilator, an ambu bag would be appropriate. Most of the time, if it's a suction issue, ambu bag would not be your line of choice, because if you are forcefully pressing on the ambu bag, you could press and push whatever mucus plug down into the lung cavity, which would not be good. So we want to just oxygenate, to pre-oxygenate the patient with whatever type of oxygen that they are currently receiving. So my patient is on room air. So I'm going to allow my patient, ask them to take some deep breaths. I would have on a mask, but I'm not wearing one right now so that I can talk to you. So I'm going to ask my patient to take some deep breaths if they can, and I'm going to prepare them. I'm going to suction you. So when I press the suction adapter, see if I can, this one doesn't work. If I press the suction adapter, when my finger is over the hole, suction is engaging, okay? When my finger is off, it is not engaging, okay? I want to go into the trach about 2 to 4 inches, okay? Until you meet a little bit of resistance, and your patient will likely cough a little bit. So I'm going to always go down while I'm suctioning with my finger off. So I'm going to go down into the trach, finger off, 3 to 4, okay, I'm meeting just a touch of resistance. Okay, so now I'm ready to suction, because right now I'm occluding my patient's airway, so I want to be very quick. So I'm going to occlude my suction catheter, and I'm going to suction, suction, suction intermittently, like so, as I'm pulling back, okay? My patient's gonna take a deep breath because I'm finished. They're gonna be like, oh, I still feel like there's something in there. Do you think you can do it again? Absolutely. So I'm gonna give them some time. I'm gonna wait about 2 to 3 minutes in between, allow them to oxygenate again before I go back down. Typically, you only want to suction about 2 to 3 times in one suction session. The reason for that is for trauma, irritation to the tracheal lining, also the lack of oxygenation during the time that you do it. So I'm gonna go down again. Thumb is off, going down, feeling a little bit of resistance. Okay, Mr. Jones, I'm gonna suction, 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 and come back up. Great, I got a lot of suction out of him. I got a lot of stuff that came back, a lot of mucus, saliva, those types of things. At this point, I feel like he sounds really clear. He looks at me and tells me he feels so much better. Then I'm gonna auscultate his lungs. I'm gonna listen again. And if I feel like he sounds pretty clear, that we've gotten rid of any mucus and saliva, there's no need to do this again. These are a one-time use suction catheter. So after I'm finished with this suction session, I have to throw this away. So likely, if you have a trach or a laryngectomy patient, you would need to have several of these in the bedside. These need to be at the bedside because we don't want to have to go run to the Pyxis to find one of these if our patient had a mucus plug that was obstructing their airway. That could be bad news. So I'm going to keep several of these. So these should all be in their room. Maybe a couple, maybe just one or two, likely just sitting over here on the bedside table, okay? The other kind of suction that you might see is what we call inline sterile suctioning. This is for someone who does have a lot of mucus. Maybe they're on a ventilation device or they have a respiratory infection with the laryngectomy or the tracheostomy, that they're gonna require lots and lots of suction. This is your best friend because this stays on the patient. It allows for oxygenation to be given inside, to be set up on the other side of this valve. This particular piece would be sterilely placed inside of their trach. It's allowing, usually there's another little adapter over here to the side of it that would allow you to actually have the patient oxygenated. And this piece itself connects directly to your suction. This is your suction valve right here. So instead of having to get sterile gloves and sterile procedure every single time, my sterile field is engaged inside of this plastic wrapper. So then I can suction, I can go down the tray, sterilely suction, and pull that back out. Okay, and that would stay inside my patient at all times. And that usually stays with them. Okay, so that's one way. That's usually the better way to do this so that we can decrease the risk for infection, knowing that we're staying sterile and not have to get sterile gloved every single time. Okay, another option for a patient with a trach is sometimes they want to, if they're coughing up a lot of fluid, a lot of mucus, they might feel like it's pooling here on their chest. So they may ask you for a yonker. One big education piece here is that they need to know that they cannot stick this yonker inside or on top of their trach to their airway. So many times I've seen patients just want to hold it here on the outside just to collect any excess mucus that might be forming on their skin, because of course that can break it down. So that you might be okay with them using this as long as they're able to understand the rules and the regulations about this. This might be if they have some extra salivation in their mouth, or if they want to get any contents that's coming around on their chest, but never to go directly on the trach itself. Not a good idea. Okay, so that is how we suction a trach. So now let's review how to do trach care. So a couple of things to know about the trach. This is what the actual trach looks like inside of our patient, sitting inside their trach. You see this little puffy little area here. This is called the cuff. When the cuff is inflated, this balloon is inflated like a balloon, and the cuff inflates just like the balloon does in the Foley catheter on the inside of their trach, keeping that intact. A lot of times they are not sutured. They are just placed inside with the trach collar. That's important to know too when you're providing care, that you never want to let go of both sides of the trach collar at the same time, because if the patient coughs really forcefully while you're in the middle of changing it, the trach is going to fall out. Okay, so cuffed or uncuffed is important. Generally, a patient would have a trach cuffed right after it was surgically placed, because there may be some swelling, some angioedema going on, some trauma to the area from the surgery, and once that's healed, then after the fact, you might could take it down from the cuff to decrease the size, because that's what's opening up the airway is the cuff itself. Once your patient adapts better, then maybe the cuff is not necessary, but you need to know whether it's cuffed or uncuffed. And then there's another term called fenestrated, which means it has a hole on the inside, or non-fenestrated, which does not have a hole on the inside. Fenestrated would be for a patient who has the speaking valve placed after a laryngectomy. This allows air to flow through this tube and up into the mouth or through the trach in order to allow for speech. using several different types of speaking valves. So this is important to know if it's fenestrated or non-fenestrated so that you would know how your patient can communicate or not. Typically, if it's non-fenestrated and there is no voice box or larynx, the patient cannot communicate via their mouth or with their voice. They no longer can speak. They can mouth words to you, but there is no sound of speech whatsoever. It's very important when you're caring for a patient, specifically. Another key thing to know about is that there should always be a replacement trach, same size, same type, that stays inside the room at all times with your patient. The reason for this is, let's say that your patient, you're doing tracheostomy care and they all of a sudden start convulsing or coughing really abruptly right when you take the trach collar off, and the whole thing falls out and lands on their lap. Well, you need to have an obturator, which is this little device right here, readily available so that immediately you can put it into the tracheostoma to maintain and keep it open, to maintain their airway. This would be absolutely emergent. You would need to call for help. The surgeon needs to come ASAP to replace the new trach. But you want to have this readily available because this would need to be done within several minutes so that we can maintain the patient's airway to save and preserve their life. So obturator is very important. If the patient travels anywhere to a procedure, to a CT, X-ray, the obturator must go with them at all times for the risk of losing the airway. So you can put it in a sterile bag or keep it in its box and just send it with the patient in their chart to whatever procedural area they're going to. It's very important. Okay, so to do trach care, you're going to need a trach care kit. You need to determine if your trach is disposable or non-disposable based on the type that you have. And you also want to make sure that your inner cannula is the correct size. You can't force a bigger cannula into a smaller hole. It's kind of like square peg, round hole. You cannot do that. It has to be the right size or it's not going to be effective, and we're talking about an airway, life-sustaining device here that we need to make sure is done correctly. You also want to assess your trach ties. If they look clean, they're not sweaty, there's no drainage on them, they don't have to be changed every single time, but typically every 7 days they do need to be changed. So I'm going to get my trach care kit, and this is a sterile procedure. I'm going to assess the amount of drainage and mucus that's coming out of the trach to know what to do. I'm going to don my sterile gloves. I'm going to put those on. I'm going to assess the need to suction because I likely would want to do that before I clean the trach, knowing that if I'm suctioning, that might be messy and I might get mucus or drainage all over my patient. So I'm going to do all those things first, make sure my airway is very clear, my patient is comfortable, and then I'm going to proceed with doing the trach care. So I have a sterile drape here. So I would drape my patient like so, just to kind of keep this airway clean. Gonna don my sterile gloves. Inside my kit, I will have poured sterile water or sodium chloride, whatever is necessary. Typically sterile water is gonna be the best thing into these little reservoirs here. And inside I have some cotton tip adapters, some little bottle cleaners I like to call them, and some little pipe cleaners, because you really are essentially cleaning this little pipe area. There is a bifurcated, or what we call a drain sponge. You have to have a specific drain sponge. You cannot just go cut a regular 4x4 because of the fibers. We don't need those fibers getting inside of our patient's airway. So we want to use a bifurcated or drain sponge. That's going to go in our patient to help with drainage. And any time that sponge at any time has a lot of drainage on it, it needs to be changed, because that's going to break down the stoma area and it's going to be uncomfortable for the patient. So when I'm looking here, I'm going to have one side off at a time. I'm going to cleanse starting from the inside nearest the stoma to the outside, get a new one. And then I'm going to get all this side really good and clean. And then I'm going to replace this trach tie before I remove the other one, before I get around the trach itself. So what I'm doing is I'm really wanting to see around the stoma. I'm not wanting to move this tube too much, but I do want to see what the stoma looks like. I want to know what the skin looks like surrounding it. Is it clean? Is it dry? Is it have any redness or irritation around it? I'm going to look for all those things. Then with my pipe cleaner, this is not to stick down in here, by no means, so don't do that. That's to clean your non-disposable trach. This I might actually use to just get any mucus areas around the side. I'm not going to put anything directly into the airway unless there was a sticky piece of mucus or something that needed to be taken off. That's what I would use this for, to get that really good and clean. Then I could replace the ties at that time if I needed to. Feel like it looks really good and clean. Then I would remove one side at a time around my patient to put my drain sponge to get it good and secure and clean around my patient's neck. I also want to make sure that the trach ties are comfortable, that they're not too tight, too loose, and I'll just be honest, patients usually are very particular about this because it is a very anxious thing to think that what if this fell out? I think they worry about that, so they want to feel like it's very secure. They may actually want it tighter than it needs to be, and I can't blame them for that. So I want to make sure that it looks really good and clean. And if everything was well, I would take my disposable and put it in just like so. And that's not the right one. This one would go right in, and it usually clips right down. That's not the right one either. Where did it go? It's this one. Yeah, that's the right side. So it goes in, and you should hear it kind of clip, and sometimes you can just give it a little tug to make sure that it's on there right, but not a big tug. You don't want to pull that out, that it's good and clear and patent. Now, if the patient's cannula was non-disposable before, once you've cleaned everything, you would take it out. You're going to place it in one side of your fluid here in your pocket, right here in this little side of your fluid pocket here. Then you would use your pipe cleaner to use that sterile water to clean it all the way out, that whole inside of it. These are not used very frequently, guys, because disposable is best. It's the less risk for infection. You would want to make sure this was completely dry and intact before you place it in with any water or any residue on it. Make sure it's good and clean, and then you would insert it back. For positioning for this patient, they do need to be upright in a semi to half Fowler's position if they're conscious. If they are unconscious, it's best to lay the patient down just a touch and more laterally towards you to your side so that they're at an angle, so that you have full direct view of it in an unconscious patient. Okay, so key points: sterile as possible, maintain the airway, make sure that the replacement trach is at the bedside, know what size of trach you're working with, make sure that you know if it's cuffed or cuffless. The cuff can be removed only with the doctor's order by just taking the air out of the cuff, just like a Foley, and remove. It's usually about 10 cc's of air that can be removed. Make sure that you have plenty of care supplies at bedside: sponges, drain, gauze. You would want to have suction available. Always have suction available set up in their room with either the Yonker or the inline, or both. Probably likely would need both. Make sure when you're suctioning that you hyperoxygenate the patient with whatever means of oxygen that they are using or need. You can only go down 1 to 2 times. There are some specifics about how far on your checkoff sheet. It says, I want to say 2 to 4 or 1 to 3 inches, but the main thing is that you're able to see it here and kind of get an idea of what this looks like, so that you're better prepared for clinical. Say you should be taking care of a trach or a laryngectomy. But the number one rule is always, always, always maintain your airway, whatever that means. Okay? Thank you so much for watching About Trach Care.